Welcome everybody. Dr. Randall Wolf here. It's 5 p.m. on Tuesday and it's time for a CV Live from DeBakey. We got a really interesting show for you. I think you're really going to like this. If you think you know about closure of the left atrial appendage and you can name 2 devices, you're about 12 short of what's either available or going to be available. So there's going to be a lot of new information on this show. I think you're really going to like it. Some really interesting devices that are on the horizon. The topic is closure of the left atrial appendage. We'll talk about why. We'll talk about how. This topic, I was talking to Dr. Efrain Miranda a few weeks ago, or maybe a month ago, maybe it's 2 months ago, and Dr. Miranda said, it's been a while since you talked about the appendage. And he's right, there are a lot of new things that are now on the horizon. So we decided to put together a talk for you on treatment of the left atrial appendage with respect to arrhythmias, and particularly atrial fibrillation. We're coming to you live from Houston. Dr. Miranda is live. He is in his library in Cincinnati, which is a beautiful library, which you'll get to see a little bit of when we show you Dr. Miranda. Oh, he's on there now. Okay, so that's not a fake background. That's the real library of Dr. Miranda, and he's with Clinical Anatomy Associates. He's the CEO. And your website, Efrain, is Clinical Anatomy, right?
Clinicalanatomy.com.
Clinicalanatomy.com, a very interesting site, both for the history of anatomy and new things like this. As well. As usual, if you have a question, text us early on or on your computer. Don't wait till the end of the show. We try to get to all the questions, but the sooner you put your question in, the more likely we'll get to it. So if you're on your phone, it's 37607, and then you text DeBakey. We'll show it on the screen there. If you're on your computer, go to poll.ev and enter DeBakey, and then respond to the activity. So computer is on your left and your phone is on your right. Both ways to get us questions. The question can be for Dr. Miranda, for myself. It can be a question about AFib. It does not have to be specifically about devices to close the left atrial appendage, although that is the topic today. So we're coming to you live from Houston, Texas, Methodist Hospital, DeBakey Heart and Vascular Center, CV Live. Dr. Miranda has been on this show with me before. I particularly like working with an anatomist because we kind of think alike. I think surgeons and anatomists are usually on the same page. To be a good surgeon, you need to be based in anatomy. And we put together an article that was published about 3 months ago that you might want to look at if you haven't seen it. And it's about the Wolf procedure. And by the way, if you need a consultation, you can go to wolfprocedure.com. It used to be wolfminimaze.com. There's also the Facebook site that's administrated by Sandy Schremeyer, and that's Wolf Procedure now too, right, Efrain? Is that right?
Correct.
Wolf Procedure, and you can just go to the Facebook site. It's got about 3K people on it, so there's a lot of good information there. Our plan today is for Dr. Miranda to go through some of the background, some of the anatomy, and start to get into the devices to treat and ways to close the left atrial appendage. And then I have a couple videos, clinical videos, which I will show what we did and what we do currently. The title of the article that we put out 3 months ago, it's open access, so you don't have to be a thoracic surgeon or anatomist to get to it. It is a new look at an old problem. It's in Journal of Thoracic and Cardiovascular Surgery, JTCVS, Journal of Thoracic and Cardiovascular Surgery, and it's in Operative Techniques, and you can look for Dr. Miranda's name or my name, and it should come up on your computer. You don't have to have any special code or to get the computer. It's what we call open access. It has our article, and at the end of the article is also about a 7-minute video about the Wolf procedure, and it does show closure of the left atrial appendage. I'll show a little excerpt of that today. So what we're going to do is Dr. Miranda will screen share with us all, and he'll begin the presentation. Efrain, thanks for joining us. I think it was a good idea to do this because there are a lot of new things on the horizon. It's kind of exciting to go through the history, but then what we're looking at down the next few years and ways to close the appendage. So would you like to share your screen and get started?
Yeah, I will. I'll do that in an instant.
And again, Dr. Miranda is coming to you from Cincinnati.
I just wanted to let everybody know that if you go to wolfprocedure.com and go to the seminars tab, you will find links to that paper there also. So here's the presentation. You tell me when you see it. I think you have it already.
Yep.
All right. So what we're going to talk about today is the left atrial appendage closure devices, the pros, the cons, the different techniques. And we're going to start with what is the left atrial appendage, the LAA. Basically, it's a little component, small component of the left atrium. And we have, Dr. Wolf and I, we have had a couple seminars on the topic. There's one that I would like to remind everybody. On November 7, 2023, we did a presentation, a seminar similar to this one, where we talked about the anatomy, embryology, and details of the left atrial appendage, the detailed anatomy. So if anyone wants to see this, of course, you can see it at the DeBakey CV Live YouTube channel or at Dr. Wolf's website. So let's start. And why the management? Why close it? Why eliminate it? And before we do that, we need some definitions. Number one, a thrombus, a clot. A thrombus is the medical term for a clot that is anchored. It doesn't move. It isn't the bloodstream, but it's anchored. Now, we have several, we say thrombi. Sometimes a thrombus detaches and then starts free flowing in the bloodstream. And now it changes the name to embolus. And if you have several of them, the plural Latin term is emboli. Of course, there are some conditions where you have thromboembolism, where you have both thrombi and emboli. Now, what's the problem? These emboli will start flowing downstream, going to places where they can close off partially an artery. And that's the term we use for that is ischemia, where there's a reduction in blood flow to a specific area. And if the clot closes the vessel, the artery or the vein completely, and there is no collateral circulation, no alternative of blood to get there, then that area of the body dies, and that's what we call a stroke, tissue death or necrosis. And you will hear the term ischemic stroke. In the Why this? 91% of the thrombi observed are found in the left atrial appendage. And I want to point out this little number here, because that's a reference, either a clinical paper, a research paper, and they are listed at the end of this presentation in case someone wants to inquire more. Now, 15 to 20% of the actual strokes originate from the left atrial appendage. So it becomes a really important structure. Furthermore, the left atrial appendage is an electric source, or they call it a focus. for atrial fibrillation. So you have here two problems, AFib and stroke. And AFib is responsible for about 25% of ischemic strokes. So it is critical to manage that left atrial appendage.
Can
Now,
I
go ahead.
interject here?
Yes.
I want to expand on that just a little bit, Efrain. And that is, people may wonder, well, where are the other 80% of thrombi that go to the brain? And a common place is the carotid artery in the neck. That can build up plaque. That can either break off or it can occlude and cause ischemia to the brain. Another way that a stroke can happen may not be a thromboembolus, but it may be a hypertensive bleed. So high blood pressure, which can cause weakness in the arteries in the brain and can cause a stroke. That's not a embolic stroke, that's more of a hemorrhagic stroke. But the reason it's 20% is there are a lot of other ways to cause decreased blood flow to the brain. But as far as the heart's concerned, almost all of them come from the appendage, and almost all the time, this is when the heart's out of rhythm. Okay.
All right. So here in this cartoon, if you will, there's a left atrial appendage. If an embolus breaks free, and it will go into the left ventricle through the mitral valve and then exit through the ascending aorta, through the aortic arch. And here you see these three large vessels. I'll keep the names to myself. And these large vessels will provide blood supply to the head, the brain, and the upper extremities, the arms. But the brain is the most important organ in this case, and that's where everything happens. So there are two ways to manage the left atrial appendage. The first one is occlusion. And basically, it's like putting a cork in a bottle, just as shown here. If this is the left atrial appendage and this is the ostium, well, let's put a cork so that nothing can come in or out. Makes sense. The second one is exclusion, to separate, seal or separate the parts of a component, like a vegetable sealer here, or an amputation. In this cartoon, this would be the left atrial appendage, and this would be the act that we excluded. And what do we do with the left atrial appendage? Well, we can eliminate and remove it, or leave it in place. And if it's left in place, the body will reabsorb what's left of the left atrial appendage. So let's look first at those devices that are the occlusion kind. And there are several. There are many. The most known is the Watchman device. But there's the amulet, lamper, wave crest. There are so many. Some of them are in study. Some of them have been actually recently taken off the
Off the market?
Go ahead.
Off the market?
Yeah, off the market because of bad results. And you have some of them which are made in China, some of them which are just being recently in study. But they all do the same thing. It's like putting a cork in a bottle. That's it. Now, if we look at them, what are the pros? Well, to place the Watchman or any of these, this can be performed by an interventional cardiologist. It doesn't have to be a cardiovascular surgeon. This procedure avoids the chest incision. Why is this good? Well, there are some patients who cannot withstand the surgery. Age, physical condition. It is also available for patients with history of prior chest surgery, where the surgeon does not want to go in because it's too difficult. There are too many adhesions. Probably the most important, and Dr. Wolf, you may want to comment on this, these devices do not treat atrial fibrillation. All they do, All
Yeah,
they do is reduce the risk of ischemic stroke.
yeah, well, that's a good point. And this is something that I encounter not infrequently, and that is a patient who'd like to have the Wolf procedure, but has had a previous occlusion device. Usually it's a Watchman. And I have tested these multiple times. And when we test the appendage, it's still active electrically. So it's occluded, but it's still active electrically and can participate in the whole process of AFib. What I've been able to do in these patients is take a pen, electrical pen, and go around the outside on the base of the appendage and use radio frequency and burn that edge so it's no longer electrically active. But unless that's done, all the occlusion devices that you have just shown still leave the appendage electrically active, and I think that's a problem. Now, while I've got the microphone here, I'd like to show the ways to get a hold of us again if you have a question. And it doesn't have to be about the occlusion devices or left atrial appendage. It can also be general questions about AFib. If you have a phone, go to 37607 and then text DeBakey and then text in your message. If you're on your computer, go to pollev.com, enter DeBakey, and then respond to the activity. I'll work in the first question right now. This is for Dr. Wolf. I have bronchiectasis and asthma. I've had one cardiac ablation that failed. Would I be a candidate for the Wolf procedure? Well, the answer generally is yes. We do patients with lung diseases. Bronchiectasis is a chronic lung disease, and asthma is as well. But what we usually do is a breathing test to see what the breathing capacity is. It's a simple test that can be done in the doctor's office. We look at the numbers, and generally, if you're 60% or 70% normal, you still do fine with the Wolf procedure. So a lot of patients do have lung issues. We have a simple way to sort that out for you. So this would not be a contraindication to having the Wolf procedure. Now, we'll do one other question here. Again, now you know how to get the questions in. We'll show that up there again one more time, how to get the questions into us. Dr. Wolf, what's the function use of the pacing wire and when is it removed? Good question. Routinely, during the procedure on the right side, I place a bipolar pacing wire inside the pericardium, inside the heart sac. This wire is not attached to the heart. There are no sutures on the heart, but the pericardium holds it against the heart. This is an idea that Dr. Flagey, my mentor, and I came up with over 20 years ago. I've been using it for 20 years. It allows us to pace the right atrium. Now here's a typical scenario. Someone's been out of rhythm for more than a year. They've been on different medications that poison their AV node or their SA node, digoxin, some of the beta blockers. So at the end of the Wolf procedure, when they go back into rhythm, their heart rate may be quite slow. Could be 30, could be 40 beats a minute. With that little wire sitting there, it allows us to hook up an external pacemaker. The wire comes out through a tiny hole in the chest, a needle hole. We can hook a pacemaker to that, and then we can increase the rate, the heart rate, to 60 or 70 or 80, which is more normal. Normal is considered 60 to 100 heart rate. And over the course of a couple of days, usually your own heart conduction system wakes up, the drugs wear off, and the heart rate returns to within the 60 to 100 range, or 50 to 100, and then we can turn that temporary pacer off, and the wire just slides out before going home. So the pacing wire is to increase the heart rate, particularly in people that have a markedly slow heart rate at the end of the Wolf procedure, usually because they've been on different medications or their heart hasn't been in rhythm for a long time. And then it just slides out before going home. So again, if you have any questions, 37607, text DeBakey or go to pullev.com. These are good questions, and I'll take a break from the questions and go back to the talk. Dr. Miranda, you're back on.
All right. Well, just to finish the cons of the endocardial occlusion devices, and let's go for thank you. It still requires a patient to take blood thinners, at least anticoagulants, at least for some time. Some manufacturers say a few weeks, some say a few months, and some cardiologists just keep it for a long time. So again,
hey, let me expand on that too. When the Watchman device was approved, well, first of all, it was rejected by the FDA several times because they never showed that it decreased the stroke rate. What they showed was that people got off the stronger blood thinners, but not off aspirin, and the patients felt better. So they did it on quality of life. Well, their quality of life was better because they were off the Coumadin or the Eliquis or what have you. But they never really proved that it decreased the stroke rate. In fact, the stroke rate went up right after the Watchman was placed. So the FDA finally, after multiple applications, approved the Watchman device with the caveat that the patient should stay on aspirin for the rest of their life. Because in fact, the stroke rate went up, not down. Okay.
All right. So the next type of devices. Oh, by the way, this there's a risk of incomplete occlusion, and there's a risk of acute left atrial appendage perforation. And I think that's something that you and I talked about, and I don't know if you want to touch upon that.
Well, the problem with perforation, when the Watchman is placed, if there's a perforation, that means a hole in the appendage, then that's an acute surgical emergency. And unfortunately, yes, we take care of those patients. It happens. And it's a big deal. It's an emergency operation. Blood is lost and requires an emergency open heart sternotomy procedure. It's a big deal.
All right. Well, so here, just to show you how what you were mentioning, here's a video, one of your videos actually, that shows a excluded, it's being cut off, stapled off left atrial appendage, and you can see how it still beats. It still has electrical activity. So that's very interesting. So now let's talk about the exclusion devices. In this case, more than a device, it's a technique. Sometimes when concomitantly with open heart surgery, a surgeon may just cut the LAA, the left atrial appendage off, and suture it closed. Now, this eliminates the electrical-based atrial fibrillation. It has a complete closure rate. Of course, the surgeon is doing it, is looking at everything. There's no further anticoagulation required. And what's interesting, it may lower the blood pressure in some patients. The concise, it requires a thoracic incision. It's open chest, requires extracorporeal circulation, and can only be used with other heart surgery.
So this is probably still the most common way the appendage is closed in the United States by a surgeon. This is done most commonly during a mitral valve procedure. It can be closed from the outside, as you've shown here, or from the inside, because during a mitral valve procedure, we are looking at the mitral valve on the inside, and the orifice, the opening of the appendage, is right next to that. So it's common to close it from the inside or close it from the outside. As you mentioned, This has to be done on the heart-lung machine with no blood running through that part of the heart to do this safely. But it's done many, many times every day during mitral valve surgery and sometimes aortic valve surgery as well, but mostly mitral valve surgery.
All right. So now, another type of occlusion devices are loops. Now, these are epicardial.
Epicardial meaning on the outside of the heart.
On the outside of the heart. And they're basically a lasso, or as mentioned there, one of them is actually called lariat. It's a lasso. It is placed under fluoroscopy, and you can see the lasso here, the lariat, and there's a certain technique. It's not easy, but it can be done. These devices, of course, just like the suture exclusion, eliminates AFib from the left atrial appendage. It may decrease blood pressure. Now, unfortunately, these type do not have a full left atrial appendage closure rate. They may have a little bit of I wouldn't say a failure rate, but incomplete closure. Requires X-rays, and it's technically challenging and has a learning curve.
Well, let me interject here. It's apropos that you talk about this right now because it's rodeo time here in Houston, the largest rodeo in the world. The person who invented the lariat is Dr. Billy Cohn, a friend of mine, and he's here in Houston. He invented this in his garage here in Houston, so he called it the lariat, being from Houston and being a rodeo guy. That's why it's called the lariat. It's not put in by a surgeon. It was invented by a surgeon. Dr. Cohn's a heart surgeon, but it's put in by the electrophysiologist. But what it requires is that a magnet be placed up through the groin, across the septum from the right atrium to the left atrium, and then the magnet is pushed out into the left atrial appendage on the inside. Then the electrophysiologist has to make an incision on the chest and enter the heart sac, the pericardium, with another magnet and bring that into place next to the magnet that's inside the appendage. These two magnets attract, one's inside the heart, one's outside the heart, and then the lariat slides over the outside of the heart inside the pericardium. The advantage is the chest incision is quite small. It's very small. But the disadvantage is you have to be pretty talented to put one of these in. And as you mentioned, sometimes they aren't placed properly. You can imagine an appendage that has 4 fingers like this, and the lariat may go over these 3 and leave one open. And that gives what Dr. Miranda mentioned, a partial closure of the appendage. And since it's not done under direct vision, it's done under fluoroscopy and X-ray, there is this possibility of not surrounding the entire appendage with the lariat device. So it's invented here in Houston by Dr. Cohn for electrophysiologists. The use of the lariat went down almost to 0, but it's actually stepped up a little bit here in the last several months. I think because of the advantage that you mentioned, when you use a device that closes off the appendage completely, then and it constricts it, then it essentially kills the appendage and it's no longer electrically active. So the lariat makes the appendage no longer electrically active, placed by an EP. The Watchman placed by an EP does not render the appendage electrically inactive. So that's one advantage. All right, Efrain.
All right, so not all anatomy of the left atrial appendage can be captured with the lariat, and that's probably what you were saying, one of the problems. Now, this is an interesting, this came out this year, later last year, And this is an endocardial loop by Append Medical. It's a new company. And there's a video here that's very interesting. Let's play this. See, it goes in.
Through the femoral vein.
Through the vein. They pass it from the right atrium to the left atrium, as you mentioned. A little vacuum device, not a magnet. A little vacuum device goes inside the left atrial appendage, sucks it in, and turns it outside in, almost like like a pillowcase. This little vacuum base, and then at the base, you see this loop, which closes off the left atrial appendage, and the suture is cut, as you see here. And the appendage is left inside, and since it's close to the neck, it will slowly be absorbed by the body. If anyone is interested in looking at this video, there's a whole hour-long video. You can go to appendmedical.com or YouTube, and this is, again, something fairly new.
Now, this device has been used clinically, but not very much. It's new. It's essentially an inside-out lariat. So the lariat goes on the inside of the heart instead of the outside of the heart. If you do a little research, you'll find that the person on the board of directors of the company that owns Lariat is one of the inventors of this device, different company. It's an Israeli company. But I call it a lariat inside out. Now, there's a lot of skepticism about having the appendage inside the left atrium and that it would be prone to thrombus, as you talked about. But so far, that's not been the case. These patients are anticoagulated for a few months, but they've shown on serial echocardiograms that appendage does sort of just become a little nub, just like it would on the outside. So the jury's out on this, but I think it has a lot of promise. I think it may take over the market, and instead of a Watchman, you may be hearing about the Append device. Okay.
Interesting. So, continuing, we have epicardial exclusion devices, clips and staples. Let's start with the staples. And this is actually, I drew the staples here because you couldn't see them very well. But here's a staple line on the left atrial appendage. Of course, on the patient side, on the wall of the left atrium, there's another line and everything's close. And I think this is the technique that you initially used 20 years ago, is that not?
That's how I started. That's what we had available. Really the only thing available. And I'd been using the stapler for different lung procedures and other procedures inside the chest. So I was quite comfortable with it. This particular stapling device at the time was also made in Cincinnati by Ethicon Endo, and you and I both worked for them at different times. So we were both familiar with it. It was safe, it was reliable. And I used it in over 1,000 patients, removing the stapler. Dr. Otsuka, who was a fellow of mine in the past, who's in Tokyo, some of you know about the WO procedure, Wolff-Otsuka procedure. He still staples them, mainly because of the cost of the clip in Japan. The clip is very expensive in Japan. The stapler is rather inexpensive, maybe $400 to use the stapler. In Japan, the clip is maybe $6,000-7,000. So for cost issues, he still uses the stapler. I've pretty much gone to the clip, but you'll talk about that now.
Yep. Did you have a video on the?
Yeah, we can go to that. Let's go to that. We'll talk about them. Let's open this up. And if you'll, Mr. Producer, you're on my screen now. By the way, that's my screensaver. That's the farm outside of Cincinnati, and one of my favorite times of the year, baling hay. Those are fortunately round bales now, so we don't have to haul those other bales around. This is during the procedure. We do the clamp to make the lines to block the electrical energy, and this is the kind of view we see when we're all finished making the lines and we block the ganglionic plexi. Then we go to closing the appendage. This is on the left side. The head is up at the top of the screen, the feet are at the bottom, the middle of the chest is to your left, and the arms are out to your right. You can see this is an older video when I was at the University of Texas, UT Health and Memorial Hermann. And this is when I was still using the stapler. Here's the stapler in place across the base of the appendage. It, as Efrain said, it fires staples on both sides and cuts down the middle. And then the appendage is removed. It's gone. It's on the back table. So this is what an appendage looks like after it's been excised. And you don't have to worry about this appendage being electrically active anymore because it's not inside the body anymore. And for about the first 1,000 cases of what was then called the mini maze, now renamed the Wolf procedure because it's really not a maze, there you can see the base of the appendage and the staple line, and that's what it looks like. Now, I moved on to the clip. The initial clips I didn't like. The delivery device was too bulky, so I kept stapling until we came up with what I wanted, which was a V-shaped device, which you'll see fits on very much like the stapler. The V opens up. The V is at the base. This is made of titanium and covered in Dacron to make it nice and soft on the outside. Just like the stapler, the clip is placed at the base of the appendage. The heart's to your left. You can see the coronary arteries there. The clip is then released so the appendage can remain intact, but it is not electrically active because it's completely sealed off, and we've done the experiments. After about 10 minutes, there's no more electrical activity in that appendage. Generally what I do, and I did it twice today, one on a patient from Kansas, one on a patient from Indiana, is I cut the tip off and freeze it. I'd like to look at it under the microscope, look at all these someday. It also empties out the appendage. So here we're cutting the tip off the appendage. You got to trust the clip. So the clip's in place, so you can see there's no flow in the appendage, and that's how I document that the appendage is completely closed. There's no longer any flow in the appendage. And there you can see the open tip of the appendage. And this is pretty much what I do every day today, is put the clip on and then open the appendage to document that there's no flow. And there you have it. All right, let's go back to the slides.
All right. So we talked about the staples and the clips. And in the market today, there are basically two clips, the Atria clip by AtriaCure, company in Cincinnati, Ohio, and recently introduced to the market the Penditure clip by Medtronic. Here is you can see an atrial appendage in place, And in the neck, you see here the AtriClip. So let's look at the pros and cons of these clip devices. So the first thing, and this is something that probably Dr. Wolf will want to make a comment, it can be used concomitantly with other cardiovascular procedures instead of just cutting and suturing. And this has become a Class 1A recommendation. If you are in the heart, if you're inside the chest, if you're inside the pericardium, working on anything, why not place that clip? You have any comments on that?
Yeah, well, the clip is a little bit faster, it's a little bit easier, and it's a little bit safer. And I mean a little bit, not a lot. But generally in surgery, if something's a little faster, a little easier, a little safer, it will gain market share. So now routinely the clip is used in many, many open heart surgeries. Even in patients that don't have AFib, it's put on prophylactically. Prophylactically means in advance of the AFib, in case of the AFib. And here at Methodist, not all the surgeons, but most of the cardiac surgeons will place the clip at the end of the open heart procedure, even in patients that don't have AFib. There is a large-scale study underway with AtriCure looking at the effect of this type of treatment. So the clip has become quite common.
Yep. All right. So going back to the presentation, we have the electrical isolation of the left elbow appendage. That's great. And the other thing is you can adjust the clip before deploying it. And this allows for really assurance of its location. And by that token, it's amenable to all the anatomical variations of the left atrial appendage. It will or it may reduce blood pressure in hypertensive patients. There's the rare, and I really mean rare, potential for incomplete closure. And I don't know if you have any comments on that.
Yeah.
Almost no cons.
Yeah, I mean the only thing that can happen adversely that I'm aware of, well, the base of the appendage could be torn by the surgeon not being meticulous. The other possibility is the clip is not placed right at the base of the appendage. You really have to get that clip at the base of the appendage to close the appendage completely, and it has to be done carefully. I think you could see in the video it was very clearly at the base of the appendage, but it could be accidentally not placed at the base. That's the main thing I would say that can happen. Let me also catch up with a couple questions here, Efrain. Does Dr. O, this is Dr. Otsuka in Tokyo, who's a previous fellow of mine, who does about as many of these procedures as I do now. Does Dr. O remove the left atrial appendage sometimes and staple other times? Well, the current stapler that he uses is the one that you saw in the video. And as Efrain mentioned, it actually lays 3 rows of staples on each side and then cuts down the middle. And the way it works is there are 3 prongs that are going down through the stapler after you close the stapler, and they're dropping 3 pins on each side, and then right behind that, like my thumb, is the knife. So the knife is going right behind it. So pretty much they're stapled and removed at the same time. There are staplers made that do not have the knife. So you lay the staples down, but the appendage stays in. But I don't think Toshi uses that stapler. It's a little bit bulky, and then the appendage is still in your way. So as far as I know, they're stapled every time with the stapler that has the knife that goes down the middle and removes the appendage. Here's another question. Can a person feel the clip on the left atrial appendage? Not to my knowledge. I don't think there are any sensory nerves on the appendage, but let's ask the anatomist.
No, no, a person will not feel it. It's like having any other implant. No one can feel a hip implant. So, no.
Yeah, the answer would be no. Okay. Let's see. Do you have anything to finish up here, Efrain?
Yeah. Well, basically, this is in closing, the exclusion or excision, occlusion, exclusion, excision, it decreases the stroke rate. It decreases the heart failure, improves quality of life. There's no doubt about that. There's a couple of papers that show that eliminating the left atrial appendage lowers blood pressure.
Yep.
Patients are rehospitalized less, and there is an increased survival. So, what I would like to, I'm going to leave this for an instant. These are the references. And again, if anyone wants to look them up, most of them are open access. You can just copy, paste, and get additional information. So that's all I have for today. And
well,
I don't know if you have any more comments, questions, or.
I do have a couple comments.
Go ahead.
I think whenever possible, it's best to eliminate the appendage and not stick a cork in it. And a good example is the patient we did this afternoon. She had an absolutely huge left atrial appendage. I wasn't even sure the largest clip would get across it. It just barely got across it. But that appendage takes up a lot of space and has a lot of electrical activity in it. So by closing a large appendage, you've eliminated a lot of abnormal electrical activity of the left atrium. It was huge. Her left atrium had a volume of almost 200 milliliters, which is twice normal size. And a large part of that was the appendage. So by closing the appendage, we've really reduced the size of the left atrium. And in patients with AFib, that's a good thing. And you reduce the amount of tissue that can fibrillate, and that's a good thing. And you reduce areas that may initiate some of that fibrillation. So that's a good thing. So it's a big advantage to close it instead of sticking a cork in it. Secondly, the initial study that showed the decrease in blood pressure compared a group of about 50 patients that had the Watchman, or as you said, the cork in the base of the appendage, versus the Lariat, which you showed, which totally occludes the appendage, and essentially it dies. In the patients who had a Watchman, there was no change in the blood pressure, which you would expect because the appendage is still hormonally active. There are hormones that are released from the appendage. In the Lariat groups, that's the group of patients where their blood pressure was lower and they showed lower renin, angiotensin. These are proteins that are released that act on the kidney and have to do with high blood pressure. These decreased in the Lariat group. They did not decrease in the Watchman group. So it was a very nice study to show the difference between sticking a cork in something, aka Watchman, versus closing it off with a stapler or the Lariat or the clip. The third thing I wanted to mention is there is another device that we did not show today, but it has been used clinically. Again, it's early on, and it's for the electrophysiologist, not for the surgeon. And it's a little bit similar to the video you showed where you grab the appendage and pull it in to the left atrium. But instead of then putting a suture or a wire around the base after the appendage has been pulled into the atrium, it twists it. So it twists the appendage on its base, until it closes itself off. So it's twisting it until it's completely closed off, and then it's clipped. And that device has been recently acquired by a large company, I think J&J, for an unbelievable amount of money. So that may have some place in our future management of the appendage as well. So overall, ladies and gentlemen, we presented to you surgical ways to close the appendage, non-surgical or minimally invasive ways that the electrophysiologist uses to close the appendage today. I think it's can be helpful to you when you think about the treatment of atrial fibrillation and what's your best treatment for closing the left atrial appendage to prevent strokes. I want to thank the people who sent in questions. I want to thank Dr. Miranda for putting this talk together and kind of updating us on this subject after a couple years. I think it's very appropriate. If the patients or people have questions, they can contact you through clinical anatomy, is that right?
Clinicalanatomy.com.
Clinicalanatomy.com. If you have questions for me after this, you can go to wolfprocedure.com, or you can also go to the Facebook site, and we'll try to answer your questions. We will be back with you in about a month, first Tuesday of next month at 5 p.m. Central Time, again live from here in Houston at DeBakey Heart for another CV Live. Dr. Miranda, thanks so much. Great presentation. Appreciate your help.
All right. Take care. Thanks.
So long, everybody.